Therapy, as well as a Certified Dry Needling Practitioner. Ready? He started his private practice with Steve Foster in 2006, called TherapySouth. Since that time, they've opened 38 clinics in Alabama, Georgia, and Mississippi. Doug is active in coaching youth sports, teaching Sunday school at his church, staying involved in the community whenever possible, and in his spare time, he enjoys cycling, hiking, playing tennis, and the occasional round of golf. Dr. Dewey Jones is a board-certified orthopedic surgeon practicing at Southlake Orthopaedics in Grandview. He offers his expertise in treating adult and pediatric patients with musculoskeletal conditions. He also offers treatment in sports medicine, arthritis, and workers' comp. Dr. Jones has an interest in arthroscopic and minimally invasive techniques of the shoulder and knee. Dr. Jones graduated from Vanderbilt University with a BS in molecular biology in 1991, and he got his medical degree at the University of Alabama School of Medicine in 1995. He also enjoys playing golf and skiing when he is not too busy in the operating room. Please welcome Dr. Jones and Doug Cole.
Thank you all for having us. Can you hear okay? Okay.
Can you hear okay here? All right. Good.
I was going to say, just looking at the agenda, I think we're the only non-attorneys on the agenda there. So if anybody has any good attorney jokes, now's the time, because you're not going to offend us. So yeah, I think we're here to act as kind of a medical panel, and we've got some prepared things to go over, but really want this to be interactive. So if you have questions as we're going through, feel free to raise your hand, speak up. We want this to be as productive as possible for y'all. So really, and I think you can go ahead and advance the slide if you want. Really, why are we here? And almost, there we go.
That's it. And the reason we're here is because this is what the workers are doing out there. We give out awards every year. I see people with broken arms, broken legs, and everything like that. And that's just exactly how high did you fall and how did you get up there? And it amazes me the number of pictures that show up. This gentleman decided he could put a few different ladders together to change that light bulb in the middle. Of course, you could always use a dumpster or something to get a little bit higher. And I love the guy who likes to put the electrical drill over the pool and fall off the ladder. So, we're here because these guys are trying to get a job done any way they can. They're on a mission to do that. But sooner or later, we get an accident and something happens, and that's going to lead to a visit with us, a visit with you guys, and then a long episode. So hopefully we can usher them through those episodes. That's not exactly what we're going to talk about today. We really wanted to come and maybe offer some perspectives from both the orthopedic perspective and rehab perspectives on some of the things we've seen going on here in the last couple of years. And if you can advance the slide, I think we have a couple other descriptions where we hope to address, and maybe one more slide.
You can click
there
through.
We go. So a couple of things we thought we'd kind of touch on is how COVID has affected us and our delivery of the portion of the care that we do, maybe some of the things we're hearing and seeing from the patients that are coming to us. Another sort of novel thing that's come up is the next is telehealth. There's a lot of people asking questions about this, trying to embrace it. Doug and I maybe share a little bit of our experience and thoughts on where that might fit into this continuum of care that we're doing with that. And then the last, I think we might talk a little bit about some things that you're probably hearing about, and that's outcome measures. Certainly, at the end of this process, there's an outcome and somebody's going to have to pay and handle that. But, how do we get to that? How do we measure that? How do we frame it or something for, all the attorneys that are around here and stuff like that? So maybe first, the next slide. Oh, and anything else? This really is Q&A. We just want to get some questions coming and maybe online if anybody does. Doug, you want to talk about what you've seen in COVID?
Yeah, sure. So, it seems like it's been 5 years, not just 18 months since all this started. And unfortunately, I think we're probably going to be talking about COVID and thinking about COVID and dealing with some of the ramifications of it for years to come. And really, while COVID was going on, what we've seen in the rehab environment has been, and this is in commercial insurance as well as comp cases, where we've seen some of the impact and what you're hearing about long haul COVID cases and what that has done to these patients. And it is a real thing. It is something that is impacting people's ability to function on a daily basis. And when you think about some of the things that come along with long haul COVID, you're talking about things like fatigue and exhaustion. You're talking about chronic headaches. You're talking about chest pain, muscle aches. Everybody's heard of COVID brain. I think I've got that and I hadn't had COVID. You got 3 kids and that happens. Shortness of breath, difficulty thinking or concentrating. So think about all those things and think about a lot of your clients who potentially have gotten COVID, maybe not in a work environment, but now they're back at work. And now are they at risk of injuring themselves? Or so what types of things do we need to think about proactively from a safety standpoint? And then if they do happen to have a legitimate injury, what types of things do we have to think about as they recover from that injury? And so those are some of the things, some of the questions that I think we should at least be thinking about, and not just brushing aside that, hey, this isn't real, or hey, this isn't part of what I have to worry about, because every one of those things could impact their outcome and their ability to return to work in a timely fashion, which again, is what we all want. We all want them to go back to work. We all want them to become productive members of society again. So, we're seeing this and we're having to deal with this from a rehab standpoint, sometimes as simple as, hey, I just got to get these people able to stand up and sit down and walk and tolerate being up and moving before I can even worry about them being able to work overhead or haul this or carry that or push this and that. So just kind of needing to be aware of that is going on. And again, the research is growing every day because you're seeing all over the world people dedicating time to these problems. Have any of y'all had any of these cases where people have some of these symptoms? Does anybody have anything that you can share on that?
Getting harder to find providers that can help address these multiple issues that different campaign. So they had we started learning stuff that want to take it.
Yeah, I think there's going to be a lot more to come, unfortunately. I suspect many people who are going to feel that they got their COVID in the work environment, whether they can prove it or not, and it's going to have to be sorted out somewhere along the way. It's unfortunate. In the orthopedic and the, on the sort of surgical medical doctor side, we're all tired of COVID. I'm tired. I'm a surgeon and I've worn a mask more in the last 2 years than I've ever worn in my life of 20 years doing surgery. It's just crazy. But it's definitely affected the patient's presentations, their outlook on things. I think and you need to be thoughtful of how this affects their course of care from their injury all the way to their recovery, just in some simple facts. I mean, when we got shut down by the governor here in Alabama, we really couldn't do non-elective surgeries. So we had a lot of people on hold. These people were in extended, absences from work. And then we, reached a phase where Mike could deliver treatment, but we had to work with our hospitals and surgical centers. And, if somebody was positive, we had to quarantine them. So now you're extending a couple of weeks. We had a lot of testing going on, and all of it is very appropriate, at those times to try to figure out. And obviously the rules changed every few months. Now I'm personally have picked up a few cases where the continuum of care just stopped from COVID. Maybe they couldn't get into rehab. They either got it themselves. The clinic was unavailable to them, transportation, family members that, drew them away. So now we've got these people rolling back to me that are, I saw a shoulder the other day that's, they're like 18 months into their, injury treatment thing and still really not anywhere because the physician got sick. They couldn't be placed at, MMI and it drug on. They're now just people cycling back to me that have been kind of caught up in the whole COVID cycle that haven't, been moving through the system well. So, there has to be some patience for it. I don't know how that works out. For us, we have been able to get most people in that looks like there's anything urgent. We can work with our surgical centers and therapists and imaging centers about getting things done in an expedient fashion because, it's a work injury. We kind of feel like it's more urgent if, it is one of those types of injuries. But the other part about COVID, and I think Doug speaks to it well, is for those that have had it or been exposed to it, they are short of breath, they're tired, their rehab potential, their recovery potential, I think, is affected by it. Now, how much you can say is affected by that or the injury or the surgery, again, the judge will have to figure that out, as the lawyer told you. But it's real and it happens. These patients will tell me, maybe they had a shoulder or knee procedure, they got COVID a month later. Now they say they can barely walk down the aisle at the grocery store without taking a knee. They're just so out of breath and short of breath. And that could go on for a couple of months. You can't expect that person to rehab back to a job that was a high demand job and a higher category very safely. And obviously, if we're going to return them to work, we want them to be safe. And some of that's related maybe directly to the injury. And then it's very subjective how much is related to the exposure to COVID. And it's kind of the darndest infection. I can't understand it honestly myself. You'll see people that lose their smell, their taste, they get one back, not the other. Some people, are exhausted and short of breath. And it makes no rhyme or reason. It's not all males at 50. It's not all children. It's very interesting. And I am grateful that I think there are some things being developed, at least in our community, some long haul clinics. Now, I don't know if we're going to get them to accept this as a workers' compensation claim or something, but there are people that need that care. And I think, unfortunately, it's going to be up to the therapists and the treating physicians to try to figure out how much of this, is going to affect their return to a safe work environment. It's not easy. So bear with us if we have to figure that out. And the last part is that the patients themselves have developed a lot of anxiety, really, about it. Did I get it in the workplace? Am I safe to go back? And then you get, that more of the psychosocial stuff, but, they don't want to go to the work environment where they might be exposed again. And then we get the whole political issue about whether you got to vaccinate or not. So it's out there. We need to tease our way through it and try to keep it separated as best we can, I think. But you got to be aware of it. We're treating a whole person here. So that's important.
Kind of a bit of a, does anybody have any questions on any of that or any? I was about to say, I noticed a question there. So a little bit of a left turn, but somebody asked about virtual reality therapy. So I'm a bit of a tech geek, so I'll tackle that for a second. Does anybody in here, I'm guessing a few of you have children. Anybody ever played with the Oculus device? Yeah. Great, cheap virtual reality device. And there's actually a lot of research, a lot of development going on, particularly in the rehab space about, hey, how do we use virtual reality environments to rehabilitate patients? And there's endless possibilities. And when I think about the work comp environment, I think about, what's the one thing that everybody always wants? They want realistic rehab. They want, hey, I want my patient to think like they're getting back to work and to do things like they're getting back to work. Well, that's the kind of stuff that you're going to start seeing. And I'm optimistic about a lot of this stuff, but you're probably looking at a 5 to 7 year window where this stuff is going to become a reality. And you're going to see virtual reality being an integrated part of physical therapy and rehab and just general rehabilitation. A lot of it has to do with, the neurological aspects of rehab. And, if I can see, that, hey, I'm doing something, or if I can see that, hey, I'm working on my workstation that maybe has been uploaded into this device, then that's going to be positive reinforcement. That's going to be, it triggers some of those things in your brain that you think, okay, I can do this. Okay, and now my outcome all of a sudden becomes a little bit better. My outlook becomes a little bit better. So we're not there yet. You'll probably come across some providers that will start playing with it. It's kind of like I remember when the Nintendo Wii board came out, and we all went and got those because it's a great, cheap biofeedback device for balance. So you're going to see technology creep in more and more into the rehab setting, and the work comp crowd is not going to be left out of that. So you're going to see people that are starting to figure out, hey, how do I tailor this to a work comp patient, and how do I accelerate their outcomes, or build that confidence for them to get back to work quicker. So interesting question. Wasn't quite expecting that one, but I like it. It's good.
Yeah. And that may be a lead. I think one of the other topics we had put, the next one here, can we get another slide, I think, after this one?
Yep.
So telehealth, not virtual therapy, but still, approaching more of the digital age with delivering our healthcare and stuff. And this is something that, since COVID has come around, we all had to pivot very quickly, as everyone did in every industry, to how do we keep going, but, continue to provide what our services are. And so telehealth is still an evolution. Certainly it's been useful. It's been used, I think, a lot internationally, but it was forced upon us. We tried it a lot. And I think it has a place. I think there's a lot of interest in it, maybe in the workers' compensation arena for various reasons, but I think it's got its limits too. I will say, as a physician, I really do need to examine a patient most of the time to evaluate and make a determination. So that doesn't lend itself very well to the examination part. You can ask them on, TV to raise their hand or, pick up something, but what can you really tell about it? I think, where it might have a place is some follow-up care. If we're doing a med refill, early post-operative, just calling in with complaints. Hey, is this okay or is that not okay? There might be a good spot for telehealth in that. And it's also may have a place for those patients that are fairly remote to the people providing their care. I get patients sent to me from all over the state of Alabama. And, when somebody has to drive a long way with a bad knee, that's, difficult for them and their family, obviously. It may become the obligation of, the work comp situation to transport them. So maybe there's a place for some limited use of telehealth and those reasons, but I don't know that it can replace all of the hands-on visits with it. And, it just can't give you that quality. And then the last part is that, it definitely, if you get a patient to come in, that kind of sets the tone for how this continuum of health and this episode is going to go. We expect you to do your part, which is go get your medical care and handle it properly and stuff like that. And, you're not going to get to sit in your minivan in the Walmart parking lot and do your telehealth visit, which is a lot of what happened when I was doing COVID. We set up that platform as fast as we could for all of our patients. And I tell you, 1 out of 3 patients can figure out the technology. You would call them, they would not there. And then when you finally got them on a phone, they really were in their minivan in the Walmart parking lot, knocking the dog out of the way, going, how am I doing? I'm like, I don't know. How are you doing? It was really pretty sad. So we kind of moved away from it to some degree with it. It may have a good position though for case management. I think there's an opportunity possibly to check in more frequently, possibly in case management that could improve outcomes and speed the whole episode of care. And then I know there's some, this was going on beforehand, but with therapy, there's been some questions about, can that do the rehab? Can we use the telehealth for rehab?
Yeah, and just to piggyback on what Dr. Jones was saying there, communication is a big thing that I think we've all realized through this, that it's hard to replace this. This is the best form of communication. I've sat on enough Zoom calls in the past year and have done enough presentations over a Zoom platform. And I've sat on the other side of them too, where I've been in my pajamas and kicked my feet up and, was probably half paying attention. So, the communication aspect, as Dr. Jones was saying, that you get from being in person is invaluable. And then from a rehab standpoint, so much of what we do is with our hands. We're hands-on, we're correcting exercises. It's great. We give them stuff to do at home and I can watch them, but 9 times out of 10, I got to put my hands on them and say, no, it needs to be this way in order to make it the most useful time spent. And so it's going to be, it's hard to totally replace that. And it's kind of funny, anytime you have a crisis, you see innovation just speed up tremendously. And we saw that in the past year and we're still seeing it. And usually what happens is it swings really far one way and then they kind of realize that doesn't work. Let's come back to here. And I think that's where we're at right now. I think companies are starting to say, okay, we tried to swing into it, but it's never as good as it sounds on paper. Let's back up a little bit. So things like check-ins, things like having access for rural clientele, which is big in Alabama. When you look at the state of Alabama, we fall into, I think based on HHS, I think all but 2 counties in Alabama are considered rural. So you have a lot of people that don't have the ability to get to Birmingham to see a specialist like Dr. Jones or to come to even therapy. There's a lot of counties in the state that might have 1 therapist. And so, okay, how do we do this? How do I get there 3 days a week? I've got kids, I've got to do this. but my employer is expecting me to be there. And so there is going to be some kind of middle ground on how this gets utilized. But what we don't want to see is we don't want to see it become you sacrifice quality for savings, because the quality is still worth hopping in the car, driving to see the specialist, and letting us do our work. And so that's the I guess the caution with that. Be careful if you're being sold, hey, I can save you X amount of dollars because we're going to do all of this virtually. Sounds great. I mean, who doesn't want to save a buck? I know everybody in here, it's part of our job to make sure that we do this in a cost savings manner. But you don't want to do it at the expense of quality and at the expense of truly accountability. When we talk about a lot of our work comp patients, it's our job to hold them accountable. And that's a little bit hard to do across the screen. It's hard to do in person a lot of times, but it's definitely harder to do across the screen. So there's good things coming with it. There's some interesting things out there where you've got artificial intelligence that will have the patient stand and, hey, let me see your range of motion, and it will measure their range of motion. There's some cool stuff coming, but it's, in my estimation, is going to be a complementing piece, not a replacing piece. So I would just kind of keep that in mind as you explore that or see that with some of the providers that you're dealing with or the companies that you're dealing with. Make sure that it's not totally taking the place of this kind of interaction, because this is hard to replicate.
Have any of you used telehealth during COVID? Was that something that everybody was trying to maintain the care going? Any problems with it? I think for med refills and stuff like that, that's probably a reasonable place to do it. It's going to be hard to do it for a real injury evaluation in a rehab situation, but yes, med refills may be the place to do it. But the other places with us, though, also I would worry about documentation for it. I don't know how much they can store, if they're going to store every video, but our lawyer friends here, they want to have it all documented, and there's a lot that can transpire in the telehealth visit that he said, she said, that may never be able to be proven or not. So there's a risk of that as well. And I also think about just getting people into us in person. It's kind of like your employers that says, listen, we would rather have the injured employee sit on a stool in my factory so he feels like he's at work than have him sit at home. And it's the same kind of concept. You want to have them come see the therapists and the physicians and stuff like that. So they want to get on with it. They get tired of sitting in my waiting room after a while. They'd rather go back to work. So that's kind of works the same concept of having them sit in their sling in the store or something like that while they wait.
I will say at the peak of our use of telehealth, we were doing about 5% of our visits. We stayed open through the whole shutdown and everything. And last month, we might have done 2 or 3. Yeah. And so you're seeing people that, again, while it's a useful tool, people want to be in person. I mean, I was excited to drive up here. I feel like we hadn't had a conference here in a long time. So people want to be in person. They want to be seen and heard, not with a screen in between. So again, it will land somewhere, but it's not going to be a total replacement for this in-person interaction.
All right, and I think we had one other slide. We were going to talk about just some topics, and Doug and I just want to give our thoughts from medical and rehab side of things. We try to think of things that maybe are getting in your ear about what's the future, the telehealth, what's COVID and stuff, and then outcomes measures is something we've had a lot of people start to ask us about. And what is that? Is that something now? Traditionally, in the work injury episodes, you get injured, you get evaluated, you get treated. We need to return you to your baseline, pre-injury baseline. Where were you before you got your injury? Well, if that's our only outcome to measure, that's hopefully reasonably definable. We have some tools for that we can use, like FCEs and stuff like that. But now there's a lot of discussion, and there may be some incorporation into apparently some of the future guidelines to using some other tools out there. There have traditionally been a lot of tools used in clinical research where they can measure, the range of motion. We can look at an X-ray and take some measurements of things. And there are all these fancy, scores of things that have somebody's name on it who first wrote the paper and described it. And those are being used by some insurance companies and others to look at it, but it's really in the clinical realm. It's about, doing research and stuff. And I'm not sure how practical they will be to this arena, because besides the ones that are some objective and measurements, most of them are subjective. They're patient reported outcomes. Well, in this arena, if we start asking all the patients how they feel, we're getting nowhere. Nobody's going back to work. And the ones that really tossed around a lot, and it's really big. If you go to a large hospital system now, I think JACO or one of the larger, maybe it's CMS or something, Medicare, they're asking them to get patient reported. You want a net promoter score. Everybody wants to be liked. And so you want to get a big score for that. If I wanted a big score for that, I'd write everybody a big check and say they could be off forever, but that's not going to work, So I think when you hear some discussions about outcome measures, be a little wary about that. Yes, there are some great things that can describe the nature of an injury, but the outcome of an injury, the recovery potential and things like that, that's going to be difficult. And if we start to incorporate that in this arena, it's going to offer a lot of subjective stuff, which the lawyer and the judges are going to love, I guess. I don't know. What do you think from the rehab side? Because maybe you can speak, we've always had the objective FCE and the evaluations we can do, and that's probably our best outcome measure.
Yeah, you are, just like Dr. Jones was saying, you're seeing some payers that are pushing, and again, in the commercial arena, you're also seeing a few comp payers that are starting to push some of these outcome measures. I guess, again, the key is to be aware of, that's not your, okay, this is the only thing I'm measuring with regards to the patient's ability to get back to the baseline that they were at before. You've got things, the lower extremity functional scale, the neck disability index, Oswestry back index, things like that are useful for us to, gauge, okay, what is the patient's mindset and how are they thinking about what they can do? Because you don't want to totally disregard that. But what you don't want to do is you also don't want to say, this is the only thing that we are basing the outcome on. And so there is, again, it's that gray area that you got to be wary of, especially in the comp world where, that gray, just like I heard those attorneys speaking before, if you leave a lot to debate, well, it's going to get debated and then it's probably going to get out of hand, which none of us want these cases to get out of hand. So be aware of them, ask questions of your providers. If you see that come across, ask them, hey, what are you using this for? Or how is this determining, what you're doing in the way of treatment? And just, make sure that you're getting some information as to where these come from. Now, if we're in a room full of people interested in Medicare, we better care about that because that's a whole different conversation. But in this room, we kind of need to have a little bit of again, a caution flag to make sure that we don't jump too much into that Kool-Aid and throw too much behind that. Kind of transitioning into the FCEs, the FCE is still kind of the gold standard. If you want to know, what you're getting, what you're getting out of that worker. If you want true objective data, and I say that not all FCEs are created equal. But if you want true objective data or the best objective data, the FCE is still going to be the way to go. And that's going to give you at least a good snapshot in time of this is what they're capable of doing, and this is what they're not capable of doing. So I see the FCE continuing to evolve. Again, technology is something that is going to permeate every aspect of what we do. And the FCE is one place where technology is going to permeate and provide us more objective data, more data points with which we can look at and say, okay, it was this here and it's this here now, or hey, it should have been this, but it's showing as this. And so we're going to get the ability to fulfill what those two buzzwords are, the reliability and validity. Every time FCE comes up, those are the two words you hear. And so sometimes those are just thrown around, but as you see the FC product develop with the use of technology, those words are going to become more important and are going to be more meaningful when it comes to outcomes and what the injured worker can truly get back to doing. So really from an outcomes measure standpoint, like Dr. Jones said, it's a lot of the subjective ones be wary of. The FCE is still going to be kind of our go-to objective measure to determine what's real and what's not real.
I like the FCE. I don't use it for everybody, but if I get to the end of care and I feel like we've pretty much, had an appropriate convalescence, we'll get MMI and stuff like that, because it's objective, but mainly the validity, reliability. I don't know. I talked to some of my colleagues and, they send them off for these things and apparently they may not read them. I bring them, almost every one of them back if they're in a reasonable location to my practice and say, you'll come back after this. I will actually go over your FCE with you and your impairment evaluation if that's what we get, because I got to sign off on it anyway. So we bring them back and tell them. And I love reading the validity, reliability stuff. And I'll put it in my report. It says, listen, I have this. They say it's medium duty, but they also don't forget this passage here that says they really didn't try that hard. We're not sure how reliable this is. And for most of you, you need that, stated in the record by the provider, because then you can take it back if there's any negotiation room and, they can come back and say, well, it doesn't look like they tried that hard. And sometimes I'll throw it out. I know the FCE said this, but look, this is not reliable. I'm sorry, I have no restrictions for you. Let's move on. Sometimes I'll talk to them about it. We can leave it a little open, say, look, you're probably going to get stronger once you get back to work and actually do your work. But that, because of the objectivity of it, and because of that extra measurement, and we're not going to get that in some of these tools that are used in outcomes, like we were mentioning, that are, like I said, they're mainly for clinical research. One other place I was thinking about where this things with outcomes may have some effect, and if any of you use much utilization review from physicians who use the ODG, I have access to that. I do some utilization review sometimes, and a lot of that research that they're putting in there, constantly updating that thing, is from studies that use these subjective outcomes. So it's even that product needs to be questioned. That's an independent product even, it's not the Bible of how to take care of a patient, I don't think. So, there needs to be some back and forth on that. And unfortunately, I think we're falling into that trap of the outcomes, and that's not going to be very applicable to this environment. So using more objective things like the FC is still a really good idea if it's needed. Thanks. All right, I think that's most of the things. We wanted to open it up for some questions if you guys, since we're the only medical people here, you can ask the lawyers all the other questions. Maybe we will too, but I don't know.
I see in the back, in the back.
Uh-huh. The truth is, yes, absolutely. I mean, if I get an FCE and they just bomb, we all see these patients. I've got them in my clinic all the time. They do not want to go back to work. And so I think it's helpful to get the FCE so we get something on a piece of paper so that you've got something to back yourself up. I've got something to back myself up because we know this is going downtown eventually. And if the FCE comes in, it's not valid and, it's pretty clear and black and white there. I have no problem as a provider saying, listen, this is not valid. I know we spent the money and I'm sorry you spent the money on it, but we needed to get the documentation in place, and I'll send them back to work with no restrictions if that's what it is. But that, I think that's, in my perspective, I can do that. It's the same with the impairments. I can adjust the impairments if I need to some degree. And that can be helpful for both of us if we get down the road. Mm-hmm.
Do you ever put in there, instead of returning them to work full duty, if there is a problem? Because we certainly don't want to put them back in the environment and then not be able to do the job. Do you ever comment on the invalidity and your inability to tell what they really do? Because I know I've seen in some things that it's speculative to ascertain. Just, we don't want to put them back if they can't do it. So how
Right.
how do you weigh that?
I think you have to, maybe weigh that in what the patient's tolerance is for work versus, their actual capabilities of it. I think to answer your question, one of the tools that I like to use quite a lot is a graded reentry program. You get a guy that's been out for several months and, sure, they can do all these things in one day in an FCE, but really if they go back to the factory, are they going to be able to do this for 10 and 12-hour shifts? So I don't mind being very specific, and it could be, we're going to do 6-hour shifts for a couple of weeks, 8-hour shifts, work our way up to 12-hour shifts. We're going to start on a 30-pound. He needs endurance, conditioning. And I think it's better to do it in the work environment than a work conditioning program. Sorry, you may want to,
That's right. That's right.
when you can. I think it's better to get them in there because it adjusts their mindset on things like that. But there is unfortunately some speculative stuff. Even the FCE, what they're measuring is speculative. They measure heart rate and other things for the effort and try to kind of correlate that, but you could have a overweight, hypertensive person with high heart, or just you have white coat hypertension. They see somebody as a provider and they get nervous. So that's where you have to kind of use a little bit of your experience and subjectivity to it. That's a great question. Yeah, and I think the graded reentry programs are a great way to get these people back.
I think too, from a FCE perspective, just as in the actual doing of the FCE, a lot depends on the provider too, because if you've got the provider that's actually doing the FCE with the patient, they're going to be good at seeing key indicators and knowing when to kind of push a little bit, or knowing when, this is what I'm seeing, we can pull them back. So, again, the provider matters in the FCE because they are I don't want to say a subjective, but they're outside of that. And so a lot depends on kind of how it gets completed. And so if you see that, hey, they're not giving their full effort, and I'm going to maybe kind of, all right, let's do this again. Let's do this again. And you can kind of push to get them, to a different level, because you can see, and again, this is where technology comes in. If there's markers that you can see, they're not giving full effort. And if I have some objective data that can show that, then I have in good conscience the ability to say, let's go, let's keep going. And so that's where again, the FCE product specifically, as technology advances, you're going to see more data points captured that are going to give you the ability as the provider to say, yep, they didn't do enough, they get to keep going. And if they don't, then I can say, hey, I didn't see what I needed to see objectively. They're not giving good effort. So yeah, and I totally agree. I think, hey, the best place for them to be is at work. And if you have an employer that's willing to kind of push them and allow them some leniency, say, hey, you're going to come 4 hours, we're good with that. That's where they need to be.
And I think it's my job to determine what's their safety of being at work with their injury. Or they may not have the tolerance quite yet, but are they safe? Are they likely to re-tear their rotator cuff or mess up their knee? Well, they have a sit-down job. It's very unlikely. Let's go ahead and set them back to work and stuff like that. Maybe their endurance isn't there, but I think it's my job to determine those two things as I send them back and with the information I get from their data. So
we love doctors that are engaged and that want to read it and actually, sit down, because that makes our job a lot easier.
Yeah, and I'll call sometimes the evaluator and say, yeah, give me a little more of what happened here, and I think that's good to find out what's going on. Other questions about any of these topics or any other topics? I'm just mainly shoulder and knee these days, but I do all kinds of orthopedics in a long time. And obviously Doug's got a huge perspective on rehab and what's going on. Yes.
It can be prevented quick, but we can see a lot over the last 18 months more because prior years, related to or not, it's frozen shoulder. It seems to be the problem we have that dragged out. Can you explain this time on how to decide the prevention, maybe the best treatment? Let that drag out.
Yeah, that's even an enigma for us. I mean, I saw 3 this morning before I got here, I think. So first to understand, is the frozen shoulder a result of the treatment, or is it a result of the injury? Or there's a group of people where it's just what we call idiopathic. It just happens. There's, when you hear about a frozen shoulder, unfortunately, it's mainly females, 40 to 60 years of age. 30% of them might get it in their lifetime without any other process. So is it that? If they have it, I think there's a lot of people I've seen, and again, I see a lot of shoulder work that are stiff after their treatment, after surgery maybe, and people are getting impatient. They want to go back to work. Everybody today thinks they should be better right after surgery the next day. And they go to complain to their physician, and he just slaps a diagnosis of frozen shoulder on there. And in my experience, a lot of, I expect stiffness, and not all stiffness is truly a frozen shoulder. Some of it's just post-operative stiffness. So, you have to kind of be careful if that's really the diagnosis. And then as far as management, if it's involved with treatment, the prevention of it is probably the best thing to do. And I think that's, appropriate rehabilitation, appropriate communications with the patients. There is, if there's a lot of delay in rehab after like shoulder procedures, then I think there's a huge risk for it. There are some other underlying, probably modifiable preoperative issues like diabetes, smoking, and other things that are a little harder to affect. But, you know, having patience with that afterwards, the frozen shoulder, a lot of those people can return to work. Believe, you know, there are, like I said, there's a lot of people that get frozen shoulders that aren't related to their work injury and they function just fine. They somehow get their hair done and their shirt on and their jackets, and it amazes me. So it's so much more. I think an appropriate path of treatment for most people is probably about 4 to 6 months from where you think you have diagnosed it. They should be improving. And if they don't, in my kind of perspective of care, then I might offer them some more procedural interventions, maybe surgery or something. I may, you know, give them some cortisone shots or steroids or something in the way. But, and then, you know, another few months after that, they ought to be getting back to their baseline. So it shouldn't drag on for much more than 12 months, I don't think. Now, interesting you bring that up, because I saw a patient here this past week or so, it seems like, who was one of these ones that got dropped in her continuum of care because of COVID, then claimed a frozen shoulder. Saw a couple of people that said, well, you know, you had your surgery, you couldn't go, you got COVID, didn't go to rehab, now you got a stiff shoulder, what are we going to do next? And so that is popping up a little bit more on my radar as well. And I'm usually trying to go back with these patients and figure out if we can treat it without a procedure. Obviously, we just get them plugged back into rehab. And if that's not getting them back to their baseline, then we may have to introduce a procedure there. That's a tough one. That is very difficult. I don't know if you have any other secrets for frozen shoulder. I send them to therapy and say, please help.
Yeah, it's,
stretch them out.
you know, he nail on the head. I mean, it's, you know, and there's a limit to how much you can push someone and it be therapeutic and productive. So,
Right.
you know, you can actually sometimes irritate it more by doing too much. And so, you know, kind of the old school mentality was push, 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 push. And sometimes that push, 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 push just inflames it a little bit more and makes it hurt more. And, you know, they're not having fun, and you're seeing the physiological, you know, regression instead of progression. So there is again, one of those, that's not the diagnosis you like seeing come across, because it's not going to make you look great anytime soon.
Yeah, you
It's-
can't look
it's-
well taking care of
You're
that.
doing a whole lot of selling that, hey, this is going to get better. It's going to get better. You know,
Right.
there's a lot of psychosocial factors that you're preaching
Quite a bit.
in that.
All right. Any other questions? Yes. I'm here for everything.
For physicians that we have to do that don't understand complex. We don't have a
A resource for what? Ah, sure. Yeah.
Why is he on the panel?
Yeah. Oh, no.
And he's done 30 therapy sessions. He's not ready for that. He still thinks that he needs more therapy. He literally said it to me from 5 months ago. So what I'm saying is, other than the
Right.
say, I can't do this, y'all have any kind of
Sure. Good question. Oh, sure. I can repeat the question. You know, so if you have a physician who really doesn't seem to understand the work comp, you know, process and continuum, you're asking if physicians have a resource for it, and the answer is yes, I think. And maybe I could tell my story with it a little bit. You know, when you go through training, or at least when I went through training, you did not take care of the workers' compensation, documentation, reentry side. You know, yes, they fell off the roof, they came to the emergency room, you were a resident, you were put on the surgery, and then you were, in my program, they actually shuttled all those patients to the attendings clinic, you know, and so I guess they knew what to do. We had I can't think of any lectures or education on it in the 5 years of training that I was done. So you really did not know. And then you come into practice and, you know, you take call one night and you end up with a trauma and injury that's, you know, work related. And then people start coming at you. And, you know, the only thing you knew a case manager did was the person who got the patient out of the hospital, you know, and the nurse case management team at the hospital. And you're like trying to figure things out. to answer your question, there are resources. The American Academy of Orthopedic Surgery, if they have that, they have a great course that's offered twice a year now. A guy named Mark Melhorn, he's kind of the champion in the American Academy of Orthopedic Surgery's arena, who teaches. He's been teaching this course for like 10 years, and I went to his course, 2 or 3 years into my practice. It's now online. He's written a couple of books that are published by the American Academy of Orthopedic Surgery that you can buy, like how to understand the guides and how to understand this. But of course, your physician's got to want to do it. He can go get CME for it, and I did do that. And so that's a resource that's available, and there's a lot of that now, digital, online, not having to leave the office too much. I did learn a lot from case managers early on. I asked them. I learned the most from my peers. I asked my older physicians at that time. And they said, oh yeah, this is what you do. Now I'm the older physician and I'm teaching younger guys. I've got 2 or 3 partners that have come since I've joined the practice, and they had no clue. And the first thing I had to sit them down, I said, listen, you're not on trial here. You just need to take care of this patient like they are any other patient and do the best you can for them. And then the record will speak for itself and the process takes care of itself as the provider, physician. Just do that, And then I kind of pulled them aside and I said, and think about it this way. If, the girl who sits at our front desk got injured and she can't show up to work, and so nobody's answering our phones and scheduling our patients, you're going to be really frustrated as an employer. And we too are small business employers. And we know what that feels like to be missing a key employee. I said, think about that employer. So if they can go back to work, so you try to appeal to them that way. Now, unfortunately, a lot of physicians kind of fall into the, they just want to take care of the patient. They want to be liked by the patient and everything like that. And you can still be liked. I have a lot of grateful work comp patients, I think. I have a lot that hate me too, but, it's, but, there is unfortunately this need for the patient to, like your care. So, they say, hey, can I have a few more days off? Can I have a few more weeks off? And you just have to lean in and tap on the knee and say, I think it's time to go back to work. Your fishing can looks really good. Let's go back to work. It's time. But there is a resource, the Academy of Orthopedic Surgery. Obviously, that physician's got to be willing to pursue it. You might also, particularly if it's a hand person, and send them off to hand therapy. And I don't know what the experience of the hand therapist is and if you have any interactions there, but I'll sometimes, a therapist might say, hey, we're really not getting any better here. I think Mr. Smith's ready to go back to work. Oh, they just need somebody who they think is on their side to tell them it's okay. But many people don't find, I love a case manager on my service because it's easy. I can just hey, we need to do this, that, and the other. They've got a form, I sign it, we get it through. Somebody's going to take care of it for you. And I've even called adjusters from these big national companies and said, you really need to get a case manager to this case because we're losing control here fast. But he has a resource if he's in the academy. And even if you're not in the American Academy, they're open to anybody. So that's a good question. Interesting. Yeah, I remember being there.
I will say from the therapist side of things, we love it when case managers call us because we hate to call them.
Right.
So we love when they call us because that helps us, like he's saying, it kind of encourages you along a path. And, we're seeing them in one setting and don't have the whole picture all the time. So, we coach our folks, hey, call the case manager, call the adjuster, call the doctor, so that you're hopefully creating the big picture, because sometimes what happens is that therapist is just looking here. The doctor's looking over here, and if nobody's talking to anybody, well, then you're not getting that coordination of care, and then that will slow down the entire process. So, yeah, that I would definitely encourage communication.
All right. Any other questions? Are y'all ready for a break? I think they're ready for you. I saw a lot of candy out there. I don't know.
Well, thank you, Doug
Thank you
Cole
all.
and Dewey Jones. I failed to mention Dr. Jones is the 4th. He comes from a long line of medical professionals. So before y'all run off, we're going to have 2 different you guys can go ahead. Thank y'all so much. We're going to have 2 drawings. The first one is going to be for the Zoom attendees. And so I'm going to ask a question. And if you will respond on the Zoom platform, whoever the 4th person is that gets this answer correct will win $25. What movie does the line, "You'll shoot your eye out, kid," come from? Should I repeat the question? Are they responding? Can you see who's number 4? Hey, Kyle, can y'all help me? Who's the 4th respondent? Okay.
Wanda Furmanek.
She's from Travelers. Wanda Furmanek. Way to go, Wanda. The correct answer was A Christmas Story. Okay, question number 2 for the Zoom audience. And this is also worth a $25 gift card. And we will take whoever answers number 8 in the 8th order. Who does Macaulay Culkin play in Home Alone? Who does Macaulay Culkin play in Home Alone?
Say Carrie Irbies.
Who is it, Kyle?
Irbies.
Carrie Irby. Thank you. Thanks for y'all's participation. We're about to take, for those of you on the Zoom audience, we're about a little bit longer break. Be back by 3:30. For those of y'all in the room, we're about ready to draw 2 door prizes. If you haven't put a card in here, you might want to do that. Each of these prizes will also be worth $25. And we would encourage y'all to go out and visit the exhibitor booths